I'd just like to introduce Kylie Crisp. She's our speaker for this morning's session. Kylie she's an experienced registered nurse with a demonstrated history of working in higher education. She trained at Royal Melbourne Hospital before completing a postgrad certificate in emergency nursing at the University of Melbourne. She has worked both in Australian and UK health services, from tertiary hospitals to primary healthcare, and has been heavily involved in the change management at an early stage in her career. So her complete bio is actually available in the delegate handbook if you'd like to have a look at it. But I just also want to highlight that she is a nurse educator who specialises in mentorship, health promotion, evidence-based research and case management. She strives to empower other nurses and strengthen their delivery of patient care through the work that she does. So I just want to welcome Kylie. Thank you.
Thank you. Georgina. Good morning, everyone. So I'm currently working at the University of Melbourne. I work in the Department of General Practice. So in the Department of General Practice, we have quite a large chronic disease management group. So within that group, I am a project coordinator with the Stepping Up project, which is what I'll talk about today. And I'm also a research assistant working on CGM monitoring and sensors. I think a couple of us were talking about it last night over dinner. So I really feel honoured to be here today. It's my first APNA, so woohoo, go APNA. So it's great. Okay, so bear with me. Being a nurse, I'm not 100% with technology, but we'll get there. Okay, so today we're going to be talking about how primary healthcare nurses can step up in diabetes management. And the objectives of today are as follows: to highlight the growing prevalence of type 2 diabetes in Australia, the Stepping Up trial, which we'll cover as well, and also the key results, to describe the unique position primary healthcare nurses are in to implement diabetes management in your practice, and also implementing that project and protocol when you leave here today. So these are our topics. We have to cover diabetes if we're talking about a diabetes model of care. So we're going to talk about the scary growing prevalence really of diabetes in Australia and the cost and impact throughout Australia. We'll also cover some global statistics as well. We'll also cover information about primary care nurses and their role in diabetes, talking about intensification of type 2 care predominantly. So it's not always about insulin, it's about other ways to get people to target, so we'll cover that as well. And our CDE, which is our credentialed diabetes educator. So when I say that, I also mean a diabetes educator. Not everyone has access to a CDE, but you may know a DE. Yeah. And then implementation. So hopefully you can walk away today and say, I'm motivated, this is what I want to do in my practice with Stepping Up. So a chronic illness is an illness that is long-term with persistent effects that impact on a person's quality of life with human, social and financial consequences for the individual and their family. So that's a quote that was published by the World Health Organization in 2014. So as we know, diabetes is a chronic condition, and type 2 in particular is the most common metabolic disorder that we have worldwide. So these are our global statistics, which are quite alarming, which I'm sure as practice nurses in the room, you're all quite aware and have seen these before. So 1 in 11 adults worldwide have diabetes. 1 in 7 births, mother has gestational diabetes, and most recently I went to a conference at ADA, and we actually had midwives talking about gestational diabetes. I'd done a study in Sunshine Hospital, and it was growing. So the DEs are actually now implementing a model of care to educate midwives how to intensify care. So it's all changing. So 75% of people with diabetes come from a low to middle income family as well, which is quite significant to note. And obviously children with type 1 diabetes. So type 2 diabetes is growing at an alarming rate in both developed and developing countries. It doesn't discriminate. So as we can see here, we have over 1 million type 2s and type 1. So quite alarming for me is to see that cohort of our 60 plus age bracket. So if we talk about multi-morbidity, we're talking about this group of patients really. So again, in the Department of General Practice, lots of studies are being done currently on multi-morbidity. So if you've got type 2 diabetes and cardiovascular disease and retinopathy, asthma, COPD, it's pretty disastrous. Yeah, so they're quite difficult to manage as well. So just some stats that I found. In the US alone, 41 million people have pre-diabetes. So pre-diabetes is defined as having a raised fasting blood glucose, not yet qualifying to have diabetes, but still they possibly have a BMI over 30 as well. So we're looking at people who are quite unwell. So this is our sharp increase here. As you can see, 1990, 1.5% of the population with type 2, and over 25 years it's 4.4. They predict that this is going to triple in the next 40 years. So we've got PHNs scrambling, government, we've got universities, we've got organisations really trying to find a solution, if we can, through different models of care and different research. So out of this number, we actually have 500,000 people that are undiagnosed. So they are on our radar. Again, we're developing tools to screen these patients. What can we do for them? They don't yet have diabetes, but we know they will develop diabetes. So how can we get them into our clinic, engage with them? What medication can we put them on? How can we intensify their care? So to go back to talk about Australia, it's quite alarming to think that 1 person every 5 minutes will develop diabetes. So if anyone has been onto the NDSS website, you can actually see your diabetes map as well. I always find that incredible. Just to look at your area, look at where you work, where you live, and see how many people are registered in that area with diabetes. So we're talking about getting to target. When you work in the world of diabetes, we always talk about getting to target, and you're out there in the practices and we talk about getting to target. So the RAC GP have released guidelines that state that we want a HbA1c below 7%. But in the real world, does this happen? It's very hard. It's very, very hard. So when we talk about targets, we also have to compare the other type 2 goals for optimum diabetes management. So we've got cholesterol, blood pressure, and body mass index. So the dark green here, at the top we've got people with diabetes, and then lower we've got the general population. So out of the BMI, it's always interesting when I see statistics, what resonates with me as a nurse, what alarms me the most. And with this picture, I think it's that 13%, that dark green range there, are the percentage of people with diabetes who are in target for BMI. So even yesterday, waiting for my plane, there was an article on a surgeon who's now performing gastric surgeries on people with diabetes who are severely obese because they need to have their knees replacements, hip replacements to try and get them moving again. So it's a big problem. So again, this is comparing with our general population. So cardiovascular disease is a leading cause of death among people with diabetes, with hypertension and stroke very common as well. So as you can see, over 600,000 people have complications with cardiovascular, who have diabetes, and obviously vision loss is there, and end-stage kidney failure as well. So end-stage kidney failure, if we talk about this, on the next slide we talk about the cost of healthcare. In 2015, the Austin Hospital, they did an audit of their haemodialysis inpatients. So one patient requiring haemodialysis per year cost the taxpayer, back then it was $83,000. So if we multiply that by our population, it's quite staggering. And obviously we know lower limb amputations as well, over 3,000. I think that's actually Richard, I think that's increased now. You might need to redo these. So yeah, and again, we've got our 60 plus cohort of patients who are going to have these lower limb complications and horrible wounds that we're really trying to get on top of in general practice. So in 2005, 10,000 people with diabetes died as a result of foot ulcers and lower leg wounds. It's catastrophic. So we also have some economic and social impacts of living with diabetes. So people with diabetes with complications, so these are our patients with cardiovascular disease requiring stents, requiring dialysis, extensive wound dressings, very expensive nursing care, in and out of hospital, over 60, lots of meds, insulin. So you're looking at over $9,000. So with our supporters, does anyone know who the supporters are? What that means, that statistic? So they're our supporters are the family members, the people caring for people with diabetes. So it's not just the person with diabetes that's struggling, it's actually their husband, their wife, their daughter, their son, taking time off work, etc. So it actually affects quite a lot of our population. We're 12% globally, which is probably higher now as well. So we're all nurses, we understand GPs, we understand general practice. We probably have seen, I'm not talking to you guys over there, sorry. So we probably have seen clinical inertia in action. So clinical inertia is defined as the lack of treatment intensification by healthcare professionals despite evidence that intensification is warranted, it's needed, and it's effective, that it works. So we know the problem is huge, but we don't do anything about it. Sounds pretty cruel. I've seen it in action, obviously, with the Stepping Up project, but I remember being a district nurse, I remember watching it. I kind of reflect on when have I seen this happen in the past. It's not just the GP, it's all of us. It's all of us, it's all health professionals. So the RACGP guidelines state that to get to target, we want our patients with diabetes to have a HbA1c of 7% or lower. So in saying that, if we talk about clinical inertia, in the UK, people start on insulin when their HbA1c is 9.3%. In Australia, it's 9.4. So basically, someone with diabetes will live feeling particularly, well, not really unwell, but not well, for 8 years before their treatment is intensified to try and decrease their HbA1c. This is a global issue. It's happening in Malaysia, it's happening in the US, it's happening everywhere. It's because of factors due to clinical inertia. So if someone has a HbA1c above 9%, we know that by achieving their target, we are going to reduce micro and macrovascular changes in that person. We may even decrease the chance of them having a heart attack in 20 years' time. But it tends to be sat on for quite a while. No, the patient doesn't want to start insulin, or the patient is quite happy on metformin. Metformin is a lovely drug, it has very little side effects, but it's not working. It's not working. A lot of research out there about different medications, different injectables, not just insulin. So there are different ways that we can intensify their care. So it says there that the initiation of insulin is often delayed, but it's not just insulin, it's actually having the conversation about not shaming, but just talking about it. This is your blood work. It doesn't lie. You're not feeling well. You've got a wound on your lower leg that won't heal. Let's talk about it. What are we going to do to intensify it? Rather than, it will be okay. So lots of different factors with clinical inertia. Obviously, we have health practitioner factors, we have patient factors, and we also have health system factors. We're very busy in general practice. There's not a lot of time, which by doing this project, I've realised practice nurses are so busy, so many constraints being pushed on them every day. It's very hard to to move things without support at the top. And also with doctors, there is sometimes a lack of knowledge about how to intensify care. They don't know where to go or what to do, or they're a little bit embarrassed to say, well, actually, I don't really know what to do with this patient. Should I just call the endo, or let's just refer on? Let's just refer out, and the patient waits 6 months, 4 months to be started on insulin. So that's what we're seeing as well. So, which is the whole idea about making the changes, making this model of care work for us. So we talk about having that difficult conversation. These are all, I was brainstorming and putting these down. It's very obvious, but know your patient and their story. People with diabetes, they like to talk about their diabetes sometimes. They like to talk about when they were first diagnosed, what they were doing when they were diagnosed, or, we want to understand how long they have had diabetes. What are they currently taking? How do they feel about it? Most people with diabetes won't be saying, yay, it's amazing, it's fantastic, I love my diabetes. And people don't want to be having needles every day as well. So to develop a rapport with your patient, the idea about developing the rapport is to get them back into the practice. Rather than letting them fall through the cracks, get to know them so well that they want to come in and see you. They want to come and see their nurse. A lot of the times they like the doctor, but they want to come and see the nurse and have a chat. So build that rapport, bring them in. Express empathy and understanding. So understand their experience, especially our complex diabetes patients. They may have had an amputation, or they may be experiencing issues with their eyes, and they know that this is the beginning. This is where it starts. They've been feeling well for 10 years living with diabetes, not having tight control over their HbA1c, and all of a sudden their eyes start failing, and you're probably the first person that they talk to about it. My eyes are not doing very well these days. Okay, so now they're not going to feel very well at all. Yeah? And introduce the idea of insulin gradually and slowly. Okay? So with any nursing care, it needs to be their decision ultimately. Unfortunately, that little voice inside your head is screaming, saying, oh my God, Joe, we need to get you an insulin. This is crazy. I need help. But they were like, I'm going on a cruise. I'm going to Greece. I'll do it when I get back. These are real patients. This is what happens. They have a life. So it needs to suit their life as well. And leave our own bias at the door. We're nurses, we're very opinionated. We have a lot of knowledge. So we try and impart that on our patients. Sometimes we can be a little bit biased as well. So we need to try to change practice. So with type 2 diabetes increasing in numbers every day, we need to redesign the way that we manage diabetes in-house in our general practice environments. So we've been working really hard at the University of Melbourne with this particular model of care, but I also know in Singapore they've got a very similar model of care based on ours as well, and also in Japan. So everyone is really scrambling to change the way we manage primary health with our diabetes. And you guys are at the forefront because you're the nurses that are going to be managing them with the GPs. We want to improve the care, but it's routine care. We don't want to reinvent the wheel and make your job even harder. We want to make sure that when you see your patients, things are being ticked off as you go. It's part of a routine care by intensifying and stepping up. It's not anything out of the ordinary. Decrease waiting time. So approximately at the Royal Melbourne Hospital, it's about between 2 to 4 months to be seen by a nurse there to start on insulin. So bringing diabetes education in-house, which is great for everyone. And of course, sharing the burden of chronic disease, because it's not going to get any better. So we need to all play a part and help each other out. And most importantly, we need to empower you guys and support you in doing that. We can't expect practice nurses to operate nurse-led clinics with diabetes, manage complex diabetes, start people on insulin. etc., without giving you the right tools and the support to do so. It's not fair, and it's actually not, it's not possible as well. So it's about empowering you guys to say, we're going to support you. You can do this. We can all help. So this is just a brief ratio of number of people with diabetes per health care practitioner as well. As you can see, the endo, he's quite busy. I don't know how many participants in our project would say to me, oh, it's okay, I've seen my endocrinologist. Jack said I'm doing really, really great. I said, oh, okay, did you discuss your blood work with him? Oh, yeah, he briefly looked at it, but I said, but your pathology has gone up, it hasn't come down. So, yeah, so it's a little bit staggering. If you speak to diabetes educators, they get very frustrated with endos. There's not a lot of communication, so endos back to us in the practice as well. But if we can reorientate these roles in general practice, hopefully we get a more fluid communication. So the actual stepping up model itself, so I'm talking about it, but what is it? What does it actually mean? So the nuts and bolts of it is education, an enhanced role for you guys, for the practice nurse. So reorientating the role of the CDE, so bringing that credentialed diabetes educator into your clinic, bringing them in. And again, providing simple algorithms and tools. There's a lot of information, there's best practice out there on how to up-titrate, how to initiate insulin. So we actually provided all of our nurses with that. So we laminated things, we had tick and flick sheets, we would stick it to their desk wherever it needed to be. So the actual stepping up trial, which is what our project is based on, was published in the BMJ in 2017. So this was the stepping up trial was conducted in 2012 until January 2014. So we actually need to revisit this trial to understand the model of care we'll talk about today. So we had 266 people with type 2 diabetes across 74 practices. So we have, in research, there has to be a control arm, which is a routine care group, and there has to be an intervention group, which were the group of people who had type 2, HbA1c above 7.5%, who received this model of care, this intensification model. Okay, so we wanted to see what changes were happening between the two. So this is just a simple flow chart just to show you the process of the trial. We won't stay here for too long, I don't want to bore you. But the interesting thing with patient screening and recruitment, people were paid to be in this trial. Clinics were paid to participate. They were not paid to be part of my project, but they were paid to be part of this. So obviously we're going to have different outcomes, aren't we? Now, the patients that they recruited for this stepping up, it was about trying to transition as many people as possible who fit this very criteria to transition them onto insulin. So in terms of recruitment, it was strict. They had to be between 18 and 80, no terminal illness, no chronic kidney disease, not be on insulin, no significant mental health issues, no, did I say terminal issue? Yeah, I did. HbA1c 7.5% and on 2 or more oral agents, ready to step up. We didn't have that. We just let everyone in with our project. So I just wanted to identify that in a study it has to be very, very strict. With the stepping up in practice training in the intervention arm, that was approximately 60 to 90 minutes of intensive practice nurse, GP, CDE training, algorithms, going through case studies, blocking off that time. So you can see, comparing that with just being given some guidelines in the control group, it's going to be different, isn't it? So with our practice nurse and GP visits, if you actually go and read the outcomes paper, which is brilliant, very, very good, you'll actually see a total, there are 103 mentoring visits that were conducted over that time. So there was a lot of intensive support at a practice level. And again, this just reiterates, so we want to increase the knowledge in the trial. It was very heavily geared towards insulin, I will say that. Yeah. So the outcomes of this particular trial, so with research again, you have your primary outcomes. What do we want to achieve? Why are we doing it? What do we want to see? Okay, so in particular, they wanted to see that the intervention group receiving this model of care had a change in HbA1c. They obviously wanted to see it go down. Yeah? They wanted to see a proportion of patients who transitioned to insulin as well. And they also wanted to see the amount of people who actually achieved their target and sustained it for 2 years. They also had to test any depressive symptoms with the PAID tool. Are you familiar with the PAID tool? Yep. So they wanted to see that there were no significant changes to that, because if you're being managed under a model of care and it's making you more depressed, it's not going to work. Yeah. So I just needed to tell you that before we looked at these slides. Yep, there's been a reduction. Okay, so on average, participants were decreasing their HbA1c by 1.3. Okay, so if you look at a couple of studies in the UK PDS, if anyone's familiar with that trial, by reducing your HbA1c by 1% can actually put 20 plus years on your life. So this is quite significant. And again, we're looking at the control group in comparison with the intervention group. So these guys are achieving their target. You can actually see where they started on insulin. You can see it just kind of dips down. But the control arm has actually improved as well, haven't they? So something's happening at practice level. Something good, something amazing's happening. But we can sustain it in this intervention group right through to 24 months. So with the project, I revisited, because I was quite new to the role, I revisited some of these clinics that were on intervention, and they are still doing stepping up today. They are still, every week, doing their stepping up work. They call it the stepping up work. Okay? And they've got really tight control on their patients with diabetes, very tight control. They've established those links in the community. So this is something that can be maintained. Quite staggering, isn't it? So 70% of participants being managed under the stepping up model of care transition to insulin. So you're 3 times more likely than being managed under your routine care. And we have to put this in, it's another outcome, but there were no depressive symptoms, so that's good as well. There were no physical changes though. You would think that there might be some changes in blood pressure or cholesterol. There was no significant changes there at all. It was mainly HbA1c and people transitioning to insulin. Okay, so the Stepping Up project, that's where I come into it. This is where my knowledge is primarily. Okay, so we have the trial. The trial is safe, it's effective, it works, it's fantastic. So our local PHN, they got hold of this. We have a very good relationship at University of Melbourne with our local PHN. And they said, well, okay, this is great, but this is in a research environment. It's a study. How can we make it work in the real world? So the professor who was the lead investigator with Stepping Up said to me in his office, I don't care what you do, just make it fly. Make it fly in general practice. You're a nurse, you know nurses, you're an educator, see what you can do. It's been very, very challenging, I must say. It's been extremely challenging. So we've loved every minute of it though. It's been absolutely amazing. So everything with our project is based on the trial quite loosely. So it's been funded. So our wages as nurses, the 3 CDEs and myself, admin time, has all been funded, but that's where the funding stops. Clinics were not reimbursed. Participants, we didn't want their identification. We already collected that in the study. We're only looking at practice level changes, if that makes sense, to see if it can work in the real world. We know that it can work in the real world. but we just needed a bit more support, which we'll go into later. So we had to recruit approximately 20 practices. We didn't quite get there. And we had a catchment area that we had to work to as well, which is Yarra, Moreland and Moonee Valley. Unfortunately, when we look at the area of Yarra, is anyone here from Victoria? Yay! Yeah. So inner city Melbourne clinics, they don't have a lot of diabetes. So we would go in, we'd engage with them, we'd pull out their list of type 2 and say, you've got 2 patients. One is about to move to Singapore on business. So we really kind of struggle with some of our areas, but if it was the western suburb, we would have had 1,000 clinics out there. But just inner city, very transient. We actually had one of the university clinics at Melbourne on board as well, but very transient population. They come in and then they go, and a lot of city workers, they have a GP in the city, but they also have a GP where they live. So there's not really a lot of communication between who manages their diabetes. Does that make sense? Yeah. So it was a collaborative team project as well. So we're working with Merry, Co-Health and the Royal Melbourne Hospital. So we had 3 credentialed diabetes educators working with us throughout these practices. And we wanted to recruit as many patients as possible. And we talk about recruiting patients. Out at Co-Health Fitzroy and Collingwood, we had a really large cohort of people who were over 60, homelessness, huge social issues. We've got extensive mental health issues out there as well. So when we actually based it on the trial, we sat down, the four of us nurses, and we said, well, what are we going to do? We didn't include them on the trial, these cohort of patients. How can you start a homeless person on insulin if they don't have a fridge? Like, what are we going to do? And it was really quite challenging. But we put it out there and said, you know what, let's do it. Let's do it. Let's include everyone and let's see what happens. So that's what we did. So we're really proud of that, because we just had to kind of make the model very flexible, had to work for lots of different patients for different reasons. Compulsory, we needed a practice nurse. It's about practice nurses, and we needed a GP. So we actually ran this project as a QI activity. So we would have the GPs reflect on their practice and reflect on these numbers and the data at a practice level. And they must have PenCat. So if people are familiar with PenCat, yep. So if they didn't have that installed, they had to have it installed. Okay, so just to recap, your diabetes educator, as you're all aware, first point of call, and credentialed diabetes educators are specialists, so they have further study in the field of diabetes education. So the funding, our credentialed diabetes educators were paid by our PHN to be there, but the main question we got was, if we find a DE, who's going to pay for them? We don't have the money. So this is still the burning question as our project wraps up. How can we support this model by getting more money for practices to engage with diabetes educator? But we're aware it's on our radar, but usually we can get as you know, team care arrangement, privately paid sometimes as well, or if they're employed by an organisation, they can be bulk billed. Okay, so with our intervention, we had a lot more. So we didn't just have the education for diabetes and access to a CDE. We also had to train our practice nurses in how to look at data. What does it mean? What do those numbers mean? Where can you get this information from? How often do you pull out these lists? Is it weekly? Is it monthly? So a lot of our time was spent supporting practice nurses here. And how to build a business case. We would engage with a clinic, be fantastic, and 90% of the time the practice nurse was already there. They were already on board. But it was shut down slightly because of there's no reimbursement. Who's going to pay for this? So we needed to support our practice nurses in how to build a business case. We had to teach nurses to be a little bit business savvy, which is not really our forte. We're carers, we're nurturers, but also these days we need to be thinking about how can we bring in a clinic that's going to, in the long run, make the practice money and also help our patients as well. So that was a big part of it. Now, education on the annual cycle of care. A lot of these patients that were on our list were not on care plans. So we had to educate about care plans. So we had to basically strip it all the way back, go back to the beginning. Who's on a care plan? Who's not on a care plan? What does that mean? Have you billed for that? Yep, so they didn't actually do that in the trial as much as what we did, because we're in the real world, aren't we? This is what happens. So with our mentoring as well, being a nurse educator, I actually set up a mentoring toolkit. So when we started the process of the CDE, meeting with the practice nurse, we had to allow the practice nurse to identify what are their goals, not our goals. 3 short-term, 3 long-term goals. What do you want to get out of this? What do you want to learn? What do you need to learn? So a bit like a learning contract. And then that will be provided as a certificate for them at the end. So it kind of started that conversation to try and build that rapport between the educator and the practice nurse as well, which I think's worked very well, very well. And again, starting nurse-led clinics. So some of our practices through this education, so we're talking about practices that were on board in September, so the early ones, they're now rolling out their nurse-led clinics. They're ready, they're chomping, they want to get started. Okay, I've got my diabetes educator in with me every week. We're starting to get really good, tighter control. We've got 22 patients in the clinic now on insulin. Let's go. Management are on board. Let's do this. How do I do it? So we've actually started to support nurses in where to go to get resources and how to actually start nurse-led clinics as well. So that's been great. And obviously MBS item numbers, so that was all kind of new to me before I started, but the educators educated me in that. So every time they're seeing a patient, what are you going to claim for that? How can you make it work? So a lot of practice nurses were seeing people 5, 10, 15 minutes, not claiming, pulling out their list, planning for a case conference, but not billing anything for it. So it was all about educating, how can we work smarter? Yeah. And obviously linking to allied health as well was quite important. Our referrals have really increased towards the end of the project, but in the beginning, very few. But now we're actually getting referrals back from outpatients, if that makes sense. So at the Royal Melbourne, they're referring back into Stepping Up at CoHealth and Fitzroy. So if they see a patient on their list, they'll call the practice nurse because they know they're doing Stepping Up. They know they're getting really good outcomes and say, look, I'm sending this patient back to you. They need to transition onto insulin. I don't know how the referral came to me. Can you do it out there with your DE and your GP? No worries. Done. Bosh. One less person they have to see. So that is starting to happen. But I'm not sure if we'll see the true benefits of that as the project finishing, so we won't be investigating that, but let's hope. So with the clinical software, it was really important from the outset that we needed to educate our nurses in what it could do. So people were using best practice and Genie and all kinds of things, but we were trying to educate them in PenCat. Okay, so we wanted to have a look at their practice population. So this is an example of a baseline pie chart that we would pull out at the start of the project. Again, we wanted to capture patients at a HbA1c above 7.5%. They could be on insulin. It didn't matter, okay? But we also looked at how many meds they were on. But as you can see, with no HbA1c recorded, there's 25 there. In some clinics, that number was triple that. So these patients are having 3 visits every 2 years, but where are they? Where are they? Where have they gone? So we actually decided, as the project was evolving, let's bring these people in. Let's get them a blood test. What's going on with their diabetes? How come we haven't seen them? We're not going to reach everyone, but even if we get 5 patients out of that 25, we've done something. And that's what happened with the Stepping Up model. So these patients were coming in and they would slot back into another category so they wouldn't fall through the gap. I think with diabetes, a lot of pharmacists often say that people with diabetes come in, but they've got an ongoing script, but how often do they see doctors or their nurses, etc. So we're just trying to bring them back in. So we're hoping at the end of our project that this pie chart will change. We'll start to see a shift But from some of the data that I've started to collect, we're actually seeing, because at a practice level, nurses are really on this diabetes radar, diabetes has increased. So the type 2 population is starting to go up in some clinics because they're on the radar. Does that make sense? So I was thinking, I want to see it decrease. But it doesn't mean it's not working, it means it's working. So with our project, some of the facilitators, or the really good bits, our practice nurses have increased their education. So with some of our practice nurses at a clinic in Richmond, they had a patient only last week come in, and the practice nurse flagged it and thought, I don't really like the look of this man's pathology, it doesn't suit his presentation, what's going on? The practice nurse is already having those conversations in her head through, having 5 months of education with intensive education with a DE. So she did some more testing, she spoke to the GP, and she called our credentialed diabetes educator Meredith and said, I think this man's a type 1. I think he's got LADA. And Meredith almost fell off her chair. She said, this is amazing, this is what we want. We want to empower nurses to be able to start to make those have those conversations. What's wrong with this patient's presentation? It just doesn't look right. And it turns out that he was a type 1. So it's that confidence with type 2 diabetes as well. So obviously within our scope of practice as nurses, we can't transition people to insulin without our GP. So we need to note that as well, okay? Practice nurses are not working alone, we work as part of a team. So if someone's transitioning to insulin, they need a lot of support. We'll have the credentialed diabetes educator there with the practice nurse, with the GP, but the practice nurse leads that dialogue, which is a complete role reversal. So once upon a time, it was the diabetes educator that would say, oh, it's okay, I'll take over. I know diabetes, but now it's changing, it needs to change. So the patients are coming in more frequently now, which is great. So that cohort of patients that had no HbA1c recorded, they're now coming back in. So they're coming back into the practice, which is what we want to see. So the more they come in, we can check their care plan, check their feet, we're actually intensifying their care just by going through. And strengthening relationships. So a bit of taboo between diabetes educators and practice nurses. We don't want to share our knowledge. Oh, we can't. Well, we're experts, but we're all nurses. Ultimately, we're all nurses. So that's the message we're trying to get across. We need to share the burden of chronic disease and strengthen the partnerships we have. You guys have no time. You're all so busy. Busy. So we found that protected time, we would block off time and our practice nurse would be on reception, or we'd block off time and she would be covering phlebotomy, the pathologist, or she was covering another practice nurse who was off sick. Without that financial reimbursement, we really noticed that in our project. No financial reimbursement. Poor data systems in place. Some of the servers that clinics run off are quite small, so we found it was very difficult to get the data that we needed at times. And clinical inertia is alive and well, particularly in Parkville. Okay, so in particular we had one, I think I was telling Richard yesterday, we had one GP that had a large amount of patients with type 2 out of range HbA1cs, and when we actually approached him and said, okay, we want to use these patients for stepping up, come on, Bernie's on board, the practice nurse, we're all on board, let's do it. No, I send them out to the endo. That's what I do with my care. Nope. And the nurses said, oh, don't worry, Kylie, he's going to retire in 2 years, we'll get his patients then. So I was a bit shocked. I came back and I said to the professor, I said, is that negligence? What are we going to do with this? He said, well, you need to let it go. He's been a GP for over 40 years. He said, this is clinical inertia at its best, Kylie. Let it go. You can't fight all the battles. But I was stunned. I just couldn't believe it. So let's hope he retires tomorrow. So with our stepping up research, this is the real world. So what have we learned? We've learned that we can't push insulin straight away as we did in the trial. So we need to support our practice nurses, empower them. We need to educate our patients. So Co-Health Fitzroy and Collingwood. So one of our ladies who is homeless, she comes into the clinic every 3 days. So every 3 days she has her insulin and then she goes. Now, I wasn't sure how that was going to work, but it works for her. She always comes in, she has a cup of tea, she has a sandwich, she has her insulin, and then off she goes. And the practice nurse has got that rapport with her now. Her workers out on the street understand she's on insulin as well. So it's a little bit of improvement for her. So that's what we've learned about the real world. We need to make it flexible, and reviewing psych medications as well. So that was happening. If we've got patients with mental health issues, what medication are they on? Are they diabetes friendly? So they were some of the intensification discussions we were having as well. And not just talking about insulin, so intensifying oral agents and also looking at people on insulin. In Airport West, we have a clinic where everyone is on insulin. So many people are on insulin, it's amazing, but they're all out of target. Every single one of them is out of target. I'm thinking, what's going on here? The GP loves insulin, loves to put everyone on it, but he just doesn't have the time to follow anyone up. So everyone is on a waiting list to see a diabetes educator. So by intensifying their care, we educated the practice nurse. How can we use our 3-day profile? How can we tighten their control? So when you see them, this is what we're going to do. So we've spent a couple of months teaching her and supporting her. And so now they're working together. So in the next 6 months, they will start to see some changes there, definitely. So that's what we've learned about the real world. Okay, so to implement it in your practice, we want you to be motivated, have a conversation about type 2, and get as many resources under your belt as you can. ADEA, diabetes educators, where can we get one? What data do we use? And with stepping up, do you want your diabetes educator out there every week with you to block off that time? This is how we started. It was every week, and then it would slowly decrease from there, and now it's just a telephone call. How are you going? How is everything? So just understanding your type 2 diabetes cohort is really important. Who's out there, and what medication are they on, and what sort of intensification do they need? So we have, I just have some resources here. Now, obviously with APNA, nurse-led clinics, building business cases as well. We're talking about being, I don't know if there's anyone here from dinner last night, being business women. We're not business women, we don't understand how to sell. We need to sell. We need to get a bit more savvy, I think, when it comes to diabetes. We have to step up a little bit with that. And obviously ADEA, we can find our diabetes educator, start linking in with a DE, have a really good rapport with them, get them in every week. You know, hopefully, if the PHM will give us some funding with that. An ND briefcase. So I've been working on an online education program for practice nurses, so that's going to be released very soon, probably the next couple of weeks, and that's free. Accredited online medical education, and obviously your PHN. Go to the PHNs. They have a lot of education for champion nurses. They've got leadership courses and things like that to start getting us thinking about how we can support our practice with diabetes, and obviously the APNA ACCHET STEC program as well. That's it. Yeah. Thanks to everyone for having me. Thanks to Roche for letting me have this platform for stepping up today as well, and have a good APNA conference.